to present his second talk, second presentation, Dr. Faruk SEMIZ.
Successful treatment of hyperopia and presbyopia lenticle transplantation
Presentation, please. Yeah.
with SEMIZ surgery. To investigate the improvement in distance and near visual acuity in hyperopia and presbyopia patients after myopic lenticle transplantation, focusing on corneal shape modification. To ensure a treatment efficacy without complication by lenticle transplantation. Promising alternative, reduced regression risk for hyperopia compared to conventional methods. Enhanced correction, adding tissue instead of removing it reduces corneal instability and enhances correction for hyperopia. Reversible, the lenticle can be removed if needed. Ideal for specific patient, young patient with hyperopia and presbyopia who don't cataract. We did examination, probe, and post-op mesopic and photopic condition. This study includes total 30 patients, total eyes 40 eyes, patient with 2 eyes, presbyopia and hyperopia 10 patients, patient with 1 eye, treat hyperopia 20 patients, and age range 20 to 50 years. Inclusion and exclusion criteria, spherical hyperopia +3 to +6.50 diopter, astigmatism +75 to +1.75, corneal thickness 400 micron to 550 micron. This is important. After transplantation, corneal central thickness over than 650, big problem. Endothelial problem and overcorrection problem. For this reason, this is limitation, this study. And this operation, mesopic pupil size, very important. Donor lenticle size was set to be 0.5 millimeter larger than the recipient's mesopic pupil size for driving in the night. And the target postoperative refraction was minus 0.50 diopter. Operation 1-2 minutes for me, very easy. 1 hour after, patient satisfaction start. Visual acuity increase, corneal central thickness increase, and the Q value decrease, total RMS increase. Visual acuity increase, and postoperatively uncorrected near visual acuity 35 centimeter was Jagger 7, which improved to postoperatively Jagger 2. Similarly, preoperative uncorrected near visual acuity 70 centimeter was Jagger 6, and postoperatively uncorrected near visual acuity Jagger 3. Corneal topography, probe and post-op, total RMS, this increase, Q value, you can see, before operation minus 0.34, postoperatively minus 0.69 decrease. Probe and post-op photopic and mesopic condition, binocular reading speed 100 watts, postoperative increase. Questionnaire results, all patients completed questionnaires before and after surgery. Reading satisfaction postoperatively, computer use, and night driving satisfaction increase. This study reports 1-year follow-up data of patients with hyperopia and hyperopia with presbyopia, no rejection or complication. This results suggest that this method can effectively treat both distance and near vision, but future studies are needed. Thank you so much.
Very nice presentation, Dr. Faruk.
Thank you.
Just one query. You have taken the smile lenticule.
Yes.
And transplanted into the patient's eye. So you had a wide range of refractive error ranging from plus 0.75, plus 3 to plus 6 diopter in your patients. So how did you fashion out the SMILE lenticule for these patients? Because your outcome was very fantastic, 0.5 diopter plus, and most patients were there. So how do we manufacture or customize this lenticule to suit these patients? Size, you said rightly, it should be a 0.5 millimeter than the myopic pupil size. That is good. But taking out this lenticule, because SMILE lenticules can be very difficult to sometimes implant, because they're very thin and you can say very elastic also. So how did you fashion out the lenticule? Are these lenticules from all those patients undergoing SMILE patients, or you fashioned out separately for your hyperopic patients?
Yes. Before every week I do this procedure. Fresh lenticule I use, no bank use. We have not corneal bank for the season. I have to use.
So suppose for example, have a patient of plus 6 diopter hyperopia. Yes. So which lenticule you'll prefer?
Myopic 6.50 diopter.
Okay, I think that has to be specified in this.
Yes, yes. Minus 0.50 target dioptria I focused.
Do you treat this myopic lenticule to create the hyperopic aspheric design?
No.
With the laser application?
No, I take fresh lenticule. For example, before.
So this is not an actual titration. This is just putting the lenticule and hope that this will correct your hyperopia.
Yes.
It cannot be actual foolproof method to correct the entire range of error. So this is just adding a lenticule. And we have seen that all these stromal lenticule which we implant in the pocket, initially the thickness may be 50 to 80 microns. But if you see these patients after 1 year, the thickness of lenticule may be just 20 microns or 30 microns. Because of keratocytic activity, the thickness goes down. Yes. Effectively, your correction also will go down at that time. So that also should be assessed in these patients. Any questions? Yeah, please.
Hello, I have the question about your inclusion and exclusion criteria about axial length of the eye. Did you include it?
Exclusion criteria is important after operation corneal central thickness 650 and up problem start. And overcorrection start and endothelial problem start. And the other exclusion criteria have to donor lenticule mesopic pupil size bigger than recipient pupil size. Patient coming, yes, all day good, but night driving, big problem coming. When I start 10 years ago, first patient, I have to change lenticule. So for the season, every time this presentation, I say mesopic pupil size very important and corneal central post-op corneal central thickness 650 and up, big problem. This is very important. The others, no problem.
I think the SMILE lenticule which we would have is that it range from the 5.8 to 6.5 max. You can't make it bigger than that. So if your myopic pupil size is bigger than that, you don't have the SMILE lenticule. So that's why it cannot be customized per se. Yes. And the myopic lenticule which we extract, I'm not sure it's actually going to correct the hyperopia in a perfect manner. It's just adding the onto the corneal thickness and changing the refractive index of the cornea and making a little bump in the central area which might correct the hyperopia in these cases. So that's a hyperopic. People have designed the stromal lenticules and ablated the lenticule to correct the hyperopic, because if you look into hyperopic correction, the center to periphery design has to be changed. It's not like a myopic lenticule. So that needs to be reassessed in these cases. And only thing is, this can be reversible procedure. If the lenticule doesn't work out, you can take out. The complication which you can have, you can tear the lenticule when you are pushing inside. It may not spread correctly. Once you go inside the pocket, nothing is visible. It's very difficult to visualize. And many people would dilate the pupil So that you can see the peripheral areas and you can flatten the lenticule properly in these cases. Or many people use other dyes, like you can inject fluorescein inside the pocket. That gives a visibility. Even a triamcinolone can be injected to see the visibility of lenticule, which is spread correctly or not. Or you take the patient immediately to antersegment OCT and see the ideal position and shape of this lenticule. You can inject some epithelial cells, and epithelial ingrowth can be one of the long-term complications in these cases also. But it's a new concept. Thank you so much,
Thank
and
you.
thank you coming from Turkey to India. Welcome to India and enjoy India.